Okay, great. Let's get started. Um, Welcome to our webinar, Market Mayhem, Long-Term Care Occupancy and Utilization in the After Times. My name is Emily Trask, and I will be your moderator. I'm pleased to introduce today's speaker, Irving Stackpole. An experienced healthcare professional, Irving Stackpole has held many leadership positions and has managed engagements with hundreds of consulting clients on 5 continents as president of Stackpole and Associates, a strategy, marketing, and research firm founded in 1991. Irving is widely published and quoted, including in the Financial Times, the New York Times, Forbes, and others. Today's webinar is being recorded and will be made available to all participants after the webinar for further review and sharing. We'd love to hear from you during today's presentation, and we'll be answering questions at the end of the session. If you have a question, please feel free to send it through the chat. If we don't get to your question today during the webinar, we will be sure to follow up afterward. Also, at the conclusion of the webinar, you will see a brief survey. Please take a moment to fill it out to help us to learn from you and enhance our programming. This program has been approved for 1 continuing education credit through NAB NCERS. So without further ado, I will pass it over to Irving. Thank you.
Thanks so much, Emily. And thank you everyone for making time. And if you've just logged on and you've gone to do the dishes, I completely understand. The program will be available afterwards. And importantly, the slide deck will be available afterwards, so you can look over it at your convenience. And importantly, at the very end of the slide deck, there's a bibliography and end notes, which I hope you will find of interest. I've had a chance to look to see who's registered. I recognize a few of you. It's good to see you, or it's good to be seen. And those of you whom I don't know, one of the things that we rely upon, Emily and me and the rest of our team, is feedback about the prior webinars, feedback about the content. And one of the observations that several people have made is that I've tried to pack too much content into prior sessions. So I'm going to trim this down a fair amount and leave plenty of time at the end for conversation and Q&A. Also, what I've done is I've split up the marketing and the sales piece into 2 sessions. And next week, we'll be hosting a webinar. I think, Emily, it's at the same time and at the same sort of day.
Yes, 1 week from today.
Right. And we've provocatively titled that Selling to Survive. So I won't get into some of those details in this program and vice versa. So thank you all again for joining the program. And the first thing to observe about the technology is that sometimes it works and sometimes it doesn't. Here's the agenda. We're going to be looking at the markets for long-term care services in what is generally being referred to as the after times. Some references to the pandemic, but generally, let's get on with understanding the situation and the circumstances we find ourselves in now. And the way I'm describing this is there's mayhem in demand and supply. There's mayhem in the payers and the intermediary markets. And there's mayhem in the general economic market, the general economies in both the UK and the US where we operate. So I'm not going to belabor the point about the fact that we're in crisis, and I'm going to try to devote at least half of the time and half of my comments on what we can do now, what we've seen in terms of best of class situations in long-term care, and importing ideas from other sectors, something that the long-term care sectors in the United States and in the UK have not done generally. That is to say, use benchmarking to other sectors. So we're going to try to find some practical steps. So what do I mean by supply and demand in Mayhem? So first of all, it's important to understand that in long-term care, there are those who need and those who want. But generally, what we're talking about is we're talking about age, psychosocial, and disability qualified individuals. That's what I mean by a market. And these markets are heavily segmented. So consumers who are seeking age qualified market rate housing, for example, aren't necessarily at all the same consumers who are seeking residential care for a person with Alzheimer's and related disorders. So the demand is highly segmented. The second is in the economic environment, the economic tier of demand. A large part of our long-term care markets are heavily intermediated. That is to say, there are payers, regulators, there are rule makers that intervene in the market. So the usual hydraulics, the usual dimensions of supply and demand, even in service-based economic environments, are twisted, are changed in long-term care. What do I mean by supply? Well, first of all, it's people. So the people that provide either paid or unpaid care to persons who either want or need, this is a key part of the supply in what we refer to as demand and supply. Then there's the built infrastructure. And this is where we can really see the segmentation, because the built infrastructure serving individuals who are market rate consumers of assisted living, for example, is quite different from the built environments for people who are far more dependent and are in lower socioeconomic strata. So the built infrastructure, for example, in a nursing home is very, very different from the built infrastructure in assisted living. And then there's the systems. And by systems, I mean all of the procedures and policies, all of the technology that's applied to those people and that built infrastructure. And as we can see in long-term care, those systems are breaking down. So I'm going to give you a spoiler alert here in that there are really only 4 key survival strategies or tactics that long-term care providers can look to in order to survive the situation that I'm going to describe. The first is to defend, protect, and fortify the market share that you already have. In a stressed market, in a declining or stagnant market, earning additional market share becomes very costly. It's very difficult. So it becomes imperative for the sake of efficiency and for the sake of protecting and for loyalty purposes to hold on to what you've got, so to speak. And by that, I mean managing to loyalty. Managing loyalty is very different from managing to, for example, customer satisfaction. I've done a program and it's available on our website called Satisfaction is Cheap, Loyalty is Priceless. Because loyalty as a behavior is what we're really looking for when we're managing to satisfaction. And I'm suggesting that in long-term care, where the markets are so dire, where the markets are so stressed, where there is such mayhem, it's imperative to move right over and start working toward loyalty. We need to increase productivity and efficiency. It makes common sense. And we need to innovate and differentiate in these markets. So if Others, some of the folks that are in on this session, I know have been to other of my programs, and you'll recognize this graph. And those of you who haven't seen this before, this is probably the most important graph in the program. What this is it's a diagram of live births in the United States from roughly 1910 until 2010. And what the live births show is that from 1925 to roughly 1944, there was a very serious decline in births in the United States. What does that mean? It means that the people who were born in 1925 were, as this graph starts to decline, those folks turned 85 in 2010. 85 is an important benchmark year as an inflection point at which time most consumers begin to need or want age-qualified housing and services. As we can see in 2020, people who were born in 1935 at the absolute sulcus, the lowest point in birth rates, they turned 85. And here we are in 2023, and you can see that birth rates have started to climb up, but they're still in this demographic dip, in this very low part. And demand is driven by aging demographics. And in the United States, and by the way, this graph in the UK is even more severe. There was an even more severe dip in live births in the United Kingdom during this same period for a variety of reasons. But the point of this is that the market, the absolute quantifiable market of age-qualified individuals has been declining since about 2012, just about the same time as age-qualified housing started to be built at a more rapid rate in the United States. So the market was declining and the supply was increasing. And we see this. There's lots of evidence of what has happened here. The SNFs, the skilled nursing facility, the nursing home numbers have been steadily declining. And this isn't just as the result of financial stress, because as we can see, this is with federal stimulus money from the pandemic. So the number of skilled nursing centers has been declining. And these numbers don't take into account the closed units, the shuttered wings, the beds that have simply been taken offline. So there's been a significant decline in the number of skilled nursing centers. And I have in previous writing and articles and in previous webinars referred to this as a fatal contraction, because this contraction in skilled nursing centers it has several very serious consequences for society. The contraction has been fundamentally in the urban, in the rural nursing centers, not so much in the urban nursing centers. And it's been fundamentally among not-for-profit. So the rural and ex-urban nursing centers, the not-for-profits that are serving the lower socioeconomic tiers of those who most seriously need residential care, these are the ones that are closing most significantly. These are the ones that are the first casualties of this market contraction. So what are we seeing in the after times? We can see here from the NIC data, the NIC data, that shows the rates of occupancy in different classes of built long-term care supply. And we can see that it's declined, and yet it seems to be coming back. Not so much in skilled nursing. In home care, another form of long-term care, The rates have been fairly steady. These aren't because people don't want long-term home care. It's because one of the supply components, labor, has been severely constrained. The demand curve, as we can see here, ramps up steeply, starting especially in 2026, 2027. I'm going to use 2027 as a benchmark year. It's an inflection point. I've looked at this for both the market rate and the need-driven markets, and 2027 will be an important year in the long-term care markets in the United States. So what can we conclude here? That the markets have been declining, it's at its nadir, and it will begin to increase about 2027. And when it does, it won't look anything like the old days. My conclusion is that we're not ready for how it's really going to look. So here's some questions. Are long-term care providers contracting because of inadequate payment, inadequate supply of staff, punitive regulatory environments, restrictive intermediary standards and payments, societal stigma, cultural ageism, dilapidated infrastructure, confused, uninformed consumers? If you had to pick from among those, what would it be? Well, I would vote for all of the above. That's what can be said about the long-term care supply and infrastructure within the United States. Qualitatively, no one wants to go to a nursing home. Retirement in our culture is a dirty word. Consumers don't discriminate well between the different types of services, between the different types of built environments, and home, which is people want to stay home. Home is where the hospital is. Home is where Home Alone is. There's a new movement to create higher levels of acute services in consumers' homes. It's called hospital at home. This is basically old wine in new bottles. Home care providers have been trying to do this since the 90s. When I was with Kimberly Quality Care, we were trying to do that, to bring complex rehabilitation and care services into the home. Here's an issue that demographically and sociologically we are not ready to deal with either in the United States or the UK. And this is the absolute explosion of individuals of age living at home. And we can see here from the Joint Center at Harvard University, they have estimated that the number of individuals 80 and over living at home will explode and become a real logistical challenge for providers, and I predict a problem in the real estate market starting in about 2027, but it will really reach traction in 2038. So the other point about supply is human supply. We all know the turnover rates in long-term care. They're absolutely unsustainable. They are like, it's a self-inflicted injury in the sector. 102% nursing turnover, 79+% turnover. And depending on the study you look at, it might even be as high as 100% or more in nursing assistants. And what we know is that the pandemic has stripped away a significant number of the labor supply from the community health centers for the elderly and nursing care centers for the elderly. And the question is, how do we get those back? I watched the employment numbers in the macro data, and I believe that the long-term care sector will begin to be able to get those people back, get those employees back when the unemployment level begins to creep back up. So let's hope for a bit of bad news in the general economy, which will be good news in the long-term care economy. We can see where people have gone from community care centers and nursing centers. They've gone to doctor's offices and hospitals, they can pay more. Home health, they can offer different flexibilities than built environments can. And again, the question is, in the supply of labor in the skilled nursing environment, is this a fatal contraction? I believe it is. It's easy to see why this has happened and how we got here. The United States spends 2.5 times what any other country spends on healthcare, and only about 46% of what the other developed economies spend on long-term care. So you can see these numbers here. The United States spends about $516 per capita on long-term care, whereas they spend, it's now, this number is even higher. I think it's about $1,219 per capita on other services. So what are the decisions and what are the practical steps here that we can take? Well, typically when you talk strategically in just about any business sector, option one is to harvest. You sort of collect what you can, salvage what you can, and go home. And that's happening. Nursing homes are closing. As I pointed out, nursing homes are closing at a surprising rate, faster than ever before. At the beginning of the pandemic, I set up a Google alert for nursing homes closing. And in the beginning, I would get one a week, maybe 2 every other week. Now I get them every day. I get 3 or 4 every day. But so harvesting isn't necessarily an option. So most of us are going to opt to stay for a variety of reasons. And in the stay environment, what can we do? Well, these are the practical steps we've taken as a benchmark, as a best in class for how to survive in declining or stagnant markets. Defend, protect, and fortify the market share that you have, which means managing to loyalty. Increase productivity and efficiency, innovate and differentiate. And these can be very much interrelated, as I'll discuss. So what do I mean by defend, protect, and fortify? Well, the simplest way to put it is to keep the market share that you already have. The best way to keep what you've got is to manage to loyalty. And that means recognizing errors and recovering effectively. There can be all kinds of errors in long-term care. There can be a delay in processing the admissions inquiry. There can be an error in the exchange of information with the referring professional. There can be a misunderstanding about the medications or the equipment requirement that the person has. There can be a discharge which results in an untoward or unnecessary readmission, either to the home health agency, to the nursing center, or to the hospital. So recognizing these errors and recovering effectively is a behavioral and organizational discipline in and of itself. There is also content on our website that covers this in great detail about how to recover effectively from errors, service-related errors. I scrupulously don't talk about them as mistakes. Nobody wants to admit making a mistake. Very few people feel comfortable with that. If we change the language, we can have a chance of changing our culture, the culture within long-term care providers, which tends to push aside mistakes or not want to own up to mistakes, but which look at errors as an opportunity for service improvement, an opportunity to increase the loyalty from mega behemoth medical center by admitting an error and recovering effectively from that error. And as I've said before, this isn't managing to satisfaction, although satisfaction is important, but the real value of customer satisfaction from a business point of view is as it serves as a proxy for loyalty, behavioral loyalty, and attitudinal loyalty. Behavioral loyalty, continued reuse, further referrals, and then attitudinal loyalty, willingness to recommend, and actual behavioral recommendations. And this is customer retention. Upstream referrals from doctors, from hospitals, from other medical service providers, other community service organizations within your marketplace area, even other intermediaries. Intermediaries recognize when a service error occurs, and it's up to us to respond effectively by treating that error as an opportunity to recover effectively with that intermediary. And what do I mean by efficiency? Efficiency isn't just cutting staff or eliminating costs. Efficiency means doing the right thing at the right time. So in our environment, we need to improve productivity and efficiency. And that means in cash constrained environments, which in long-term care, that certainly describes the situation, we can avoid, should avoid, must avoid costly battles for market share. Now, battles for market share might take on a lot of different dimensions, but one of the things that we see, which is, in our opinion, an error, is advertising. Advertising generally is good for building awareness. It's good for creating maybe some preference for your service, but it's not very efficient. Direct digital marketing is far more efficient and is the kind of low cost, high impact marketing that we recommend in this constrained, stagnant, or declining environment. So direct digital marketing is far more cost effective. And what seems a paradox is that in-person or virtual sales, in-person contact, is also very efficient because it can convey personality. It can convey warmth, empathy, the kind of understanding that professional to professional takes on additional meaning, especially when that referral source says, now, should I refer some more of these cases? If the referral source is a company like Optum or another intermediary, should I refer some more cases to that provider? Or, yeah. So you want to build that kind of intimate, confident, trusting relationship that's built not necessarily on 100% satisfaction. Nobody achieves 100% satisfaction. It's built on recognizing errors and recovering effectively. The other byword in long-term care now and for the foreseeable future is efficiency. That's doing the right thing at the right time. And this is built on continuous quality improvement, which isn't just a buzzword. It's a rigorous set of disciplines, a science, an organizational science built by dozens of companies, dozens of thought leaders over decades. So you've heard of Deming, Duran, Feigenbaum, and others who have built this model for rigorous, continuous improvement in the services we provide. After all, quality is defined as the degree to which a service is free of controllable defects. And a controllable defect is an error. So identifying errors as they occur or as they are discovered and correcting them is enormously effective in building greater customer loyalty, continuous quality improvement. And this all means being faster, being better, and it also means being smarter, because I can promise you that in your marketplace area, There are only a few providers who can even have the conversation about these strategic principles. So what about innovation? So in a resource constrained environment, how can we innovate? There's lots of ways to innovate. The innovations are not limited by your capital. There are people on your team, there are people within your organization, there are other organizations in benchmarked or other sectors that are showing you, that are sharing with you how to create solutions that your customers want. I'm going to urge you to develop ways of harvesting and harnessing the innovation that exists within your team. There are people in your organization who know how to do admissions more efficiently. Ask them, talk to them, listen seriously to their insights, and attempt to engage them in implementing that innovation. And then share it. Share that innovation with the rest of the team and with your referral sources. Do you know the pain points of your referral sources? Have you looked at the public health disease burden in your marketplace area? Do you know how many orthopedic procedures your hospitals do? Do you know what Hospital Compare says about the readmissions rates at your local hospital? Do you know what's clogging up the emergency departments in your local hospital? Do you know what frets and worries the local family physicians in your marketplace area? Do you know those people's pain points, readmissions, inefficiencies, and their challenges are looking for your solutions? The limitations are not, you are not constrained by your physical environment. You're constrained by the history, by the legacy of always doing the same thing over and over again and expecting things to be different. The other thing that you can do to innovate is create partnerships, deep partnerships within your marketplace area and contiguous geographic areas. Partnerships will be the way that many long-term care providers will survive to 2027, to 2030, to 2035. These partnerships will create refreshed streams of referrals and insights. These partnerships will offer you insights about regulatory logistics, about human resources logistics, about a host of other strategic dimensions that need to be addressed if you're going to survive. So the internal and external dimensions of innovation, I would emphasize the internal dimensions of innovation. It's always surprised me that in the long-term care organizations with which we've worked, that such a small proportion, except in one or maybe two cases that I can think of, such a small proportion of the referrals come from within the organization. Are your employees, are your staff, are the families of your employees or staff, is your board, is the board of directors, the board of advisors, or your medical directors, are they referring cases to your service, to your nursing center? Are they referring cases to your home health agency? If not, why not? These are questions that can and should be asked that long for, that call for innovation. Again, innovation means being faster, better, and smarter. So what do we mean by differentiation? This is the fourth of the four key points that I'm trying to drive home here. So the differentiation is the answer to the question, which is not rhetorical. Why should a consumer choose you? Why would the family of a person with Alzheimer's and related disorders trust your home health agency? Why would they choose your long-term care center, whether it's a memory care unit in a skilled nursing or memory care unit in an assisted living? Why would they choose your center for their mother with a neurodegenerative disorder that she can't be cared for at home any longer and needs skilled nursing? Why would they trust you? This is a question that needs to be asked internally and probably ties very, very well to the innovation strategy that I talked about earlier. Next question, why would an intermediary choose you? I've sat with too many executives, too many admissions directors who are pining, wistfully hoping that they will get more of a particular type of referral, whether it's a Medicare Part A or a managed care, an Optum patient, or a why wish? Ask. We have an opportunity to bring the solutions that we have for the pain challenges, the pain points that intermediaries have, especially any intermediary that's sharing risk, like a Medicare Part C or so-called Medicare Advantage plan. These intermediaries are at risk, and if we can help solve their problem, we will become their preferred provider. And why would a referring hospital or a referring doctor continue to refer to you? Because you solve their problem, because you understand their challenges. You don't go to them with an open hand saying, please, can I have, like in that play or the movie, can I have a little more gruel? Can I have a few more referrals, please? No. You go to the hospital and say, we see that you're 4 percentage points above the national recommended standard for cardiology patients. We have an ambulatory cardiology program that can absolutely help with your episodes of care by reducing the unnecessary readmissions for these cardiology diagnoses. That's going to the provider with a solution to a problem that you have the solution to. You've got the goods. Bring it. For this, we have to go to, so this is a paraphrase of what you want every case manager, every continuing care coordinator, every doctor who's handling patients in a hospital to say about your service. Oh, for a case like this, you really need to go to Cupcake Rehab. You need to go to Golden Care, home health care. You need to go to this. You achieve that brand. You achieve that preeminent state of mind by bringing solutions and managing to loyalty. So what we've done is, I've also put the question here, if they're not using you, and maybe they aren't, which is why you're on this webinar. If they're not using you, why are they choosing the competitor? You can find out. It's eminently possible for you to determine why they are choosing your competitor. Now, in the old days, it used to be because somebody brought around a mug and donuts, a mug of coffee with donuts. The situation may still involve coffee and donuts, but it's generally somewhat more complex, and it has to do with information, which is the new coin of the realm and the new efficient model for long-term care relationship building. Information and problem solving is the coin of the realm. So why are they choosing them? Gives you an insight as to why they might be choosing you. And finally, cut through the clutter. Don't just use the same old hackneyed messaging, the same old messages about we're the best. No, cut through the clutter, identify the problem, build a solution and bring it. Bring the solution, not the problem. And then you'll be offering meaningful differences, which is what differentiation is all about. So overall, the last one standing strategy relies on these 4 pillars. Defend, protect, and fortify the share that you've already got, which means managing to customer loyalty, not managing the satisfaction, which is sort of a myth, but managing the loyalty. Increasing productivity and efficiency, innovate, and differentiate. These are indeed the standards for successful long-term care providers in an increasingly complex and mayhem-laden market. So with that, I will stop, pause, and catch my breath and ask if you all have any questions.
If you have questions, please put them in the chat, or you can raise your hand if you're interested in speaking to the group today.
There must be questions.
I have one question about when you were talking about tapping into the resources and the staff, just if you could provide some strategies on how to go about figuring out some of the best people to assign to different roles or get them more involved in helping creating efficiencies.
Right. So this is a very well-worn path. So how to implement an idea harvesting process within an established work group is well understood. The models are well developed and they exist within the well-established continuous quality care environments, whether it's the Toyota model or other types of model. I was trained in Duran model of continuous quality improvement, which relies upon grassroots feedback from frontline workers. You know, until just last year, on a Toyota assembly line, anybody could stop the assembly line. Anybody. And this was enabled because it was seen that those who are closest to the point of contact, in this case with the product, were best able to see what the problems are. If there's a problem with I'm going to use a skilled nursing environment metaphor. If there's a problem with an incipient decubiti, with a bed sore that's just starting to show, who's going to see that? The director of nursing? No. Who's going to see that? The physical therapist who goes in and maybe does some work in the room, or when the person comes to the physical therapy area? No. The person that's going to see that is the CNA, who turns, who bathes, who dresses, who cares for that person. Is that CNA authorized? I almost used air quotes. I hate those. Does that CNA feel authorized to speak up and to say, you know, I just turned Mrs. Stackpole and there's a red spot down at the top of her butt. Does she feel authorized, or does he feel authorized to bring that issue to the nursing manager on that unit or to her supervisor? Too often, the answer to that is no. She not only does not feel authorized, but she doesn't want any criticism of her work. She doesn't want to be seen as failing to having turned that person or having positioned that person. And so these incipient problems go unaddressed. Similarly, with something as big as an admissions, a referral. how much time goes between receiving the referral? If you're using something like Allscripts in a nursing environment, they come in on a regular basis. How long does it take before you get back to that referring provider with a response about that referral? Sometimes it's hours. It could be days. I say no. Why? Because, well, I don't want to call back because I don't know the answer. Well, yes, you do want to call back. Recontacting is more important with or without the answer than no contact, because no contact means no interest, or is interpreted. There's a risk of interpreting that as no interest. So the answer to your question, to that question about how to do it, is baked into the continuous quality improvement processes, which require individuals who are close to the surface, close to the service point, close to the surface too, close to the service point, and pulling them in and saying, please help us answer this question. How can we address these issues more quickly, and recruiting them in a meaningful way, and not just the usual suspects, because every director of nurses has his or her favorites. Every nurse manager, every unit manager, every home care manager has his or her favorites, not just the usual suspects, but the people who are close to the front line, and using them as the source of identifying the issues to help resolve the issues.
Great, thank you. We have John Hopkins who would like to ask a question.
Hi, Irving. I'm north of Boston. I operate assisted living, and I work with half a dozen hospitals. The hospital social work discharge planner of the past has sort of been replaced by the geriatric care manager, and there are a couple of models of how people are deriving or monetizing that segment, but it seems like there's an increasing level between the original referring parties and operators like myself. What do you think of geriatric care managers and their models these days?
Well, it's a terrific question. I have a great relationship with the Case Management Society of America and Case CMSNE, Case Management Society of New England, and believe that they are well-intentioned, well-meaning, highly functioning professionals, and I think they've completely missed the mark. Completely. And they've completely missed the mark because consumers in your marketplace area can't tell the difference between a quote unquote rehabilitation center and an assisted living. And this is proven out over and over again, because I'm really a nobody, but I get calls from family and friends and other people who say, well, Irving knows some stuff about that. Call him and ask. No, they should be calling the case manager, the geriatric care manager, and this model should be far more widely deployed. But getting to what I believe is at the heart of your question, there is no operating entity in your marketplace area who knows more about the care and feeding of healthy persons of age than you do, John. That knowledge becomes solutions for any risk-bearing entity like a Medicaid managed care or a ACO or any of the other alphabet soup that's circulating now in the intermediary market. In other words, you know what they don't, and they need what you don't know. What you know, they need it. The problem is that they probably don't know that you know and that you can help them solve their problems. So I would encourage you to design some solutions that either go right to those geriatric care managers or, frankly, around those geriatric care managers to the financial folk who are looking at the risk relationships in the marketplace area. Offer solutions that meet their needs by keeping your populations healthy. I hope that answers your question.
Very thorough. Thank you.
Great, thank you. One other question about, could you provide some specific examples on ways to differentiate a facility?
Yes. Sure. And there's no limit to this. So if I give you these examples, these are just the tops of the waves. There's no limit to the way you can differentiate your service. The critical ingredient is got to be authentic, because you can't differentiate on personalized service if you don't answer the expletive deleted phone. You can't be a Parkinson's expert if you don't know what big and loud is. You can't be an Alzheimer's expert and offer Alzheimer's solutions if your staff doesn't show empathy and patience. So those are three service lines. Those are three service areas where providers can differentiate themselves. The clinical disease burden in any marketplace area gives us an opportunity to understand where the problems are. And I can tell you, for example, one of the big problems is behavioral health. So hospital emergency departments are being clogged with cases that historically would have been referred to psychiatric hospitals and psychiatric clinics, behavioral health clinics, but those hospitals have been closed or are operating at or near capacity, and those clinics have been constrained. So how do we differentiate? Can we offer a solution for the hospitals around behavioral health that can be an intermediary to those problems? That's one way. And the other way, another way along a clinical line that I already alluded to, is by looking at the hospital compare.gov data or even local hospital data, interviewing people or going to the hospital and seeing for yourself where their clinical challenges are, where their payment challenges are, and differentiating your service through offering, for example, a cardiac services or dialysis services or a pulmonary program. But there needs to be substantive. You've really got to be able to deliver on those things. I wouldn't suggest trying to develop a pulmonary service if you don't have, for example, access to a respiratory therapist that you can use as the supervisor, as the developer, as the oversight on the program. I wouldn't suggest a cardiac rehab program unless you've got a really good physical therapy program with excellent monitoring. So these types of clinical categories offer a service line differentiation potential. And that's generally a very good way to differentiate your service within your marketplace area. I hope that responds to the question.
Great, thank you. One more. Could you please suggest how a new caregiver organization should approach a mature market? Please suggest some do's and don'ts.
Well, absolutely. Well, the first don't is don't try advertising. Use the same principles that I have prescribed countless times and that work. And that's direct marketing or one-on-one sales. So when you introduce a new service into a mature market, the critical ingredient is differentiation. You will differentiate yourself based on the label, based on your name, unless you are Mass General Home Care and you're introducing yourself into the Boston market. So that's a well-established label, and you're attempting to garner benefit from extending that brand to a different service line, a process I don't generally recommend. But if you're introducing a new service, it's newly labeled, newly white labeled, and going into a marketplace, the same principles of differentiation apply. The same principles of creating solutions. It's not just novelty. People will listen to you, talk to you because it's novel, but that's not why they will use you or continue to use you, or how you can earn market share away from the established providers in your marketplace area. You do that by solving a problem or multiple problems and managing to loyalty, recognizing when errors occur, recovering effectively from those errors, and staying in continuous contact through information distribution, through training, through information, which is the new coin of the realm, within the upstream referral sources within your marketplace area. If I didn't answer the question the way you wanted it, to ask a follow-on question, but that's a very good question.
Well, I think that you answered the question. So those are all the questions that we have. So, and we're almost at time. So did you want to say anything else in closing?
I just want to thank everyone for their time, and I can assure you that these points are well established and that they work, and that applying them requires diligence and discipline, but that they can work. And if I can help in any way further, please be in touch. And I look forward to continuing the dialogue with all of you.
Thank you very much. Thanks to everyone for attending. Please take a moment to answer the survey and let us know how we did. Have a great day, and we will send the follow-up email with the recording. Hope to see you at a future program. Join us next week for Selling to Survive, the last one standing in long-term care. I put the link in the chat. Thank you very much.